Okay, I wanted to go over some things on the acoustic reflex threshold practice worksheets that I had uploaded to Blackboard. So I think you guys downloaded those and then you tried to go over those to get the answers, and you downloaded the answers, and then you maybe had some difficulty figuring out why the answers were what they were. So I'm going to try to explain that to the best of my ability here in the short amount of time that we have. So first, what we're seeing is the problem number one, where you had normal hearing and normal auditory function in the right ear. So here's our right acoustic reflex pathway, and then 45 dB conductive loss in the left ear. And I've put the kind of the circle with the cross through it, the band symbol, I guess, over the left middle ear, because that's where the pathology is at. It's a conductive pathology. So first, let's take these in order from left to right. You've got the right ipsilateral reflex over here, unimpaired pathway. So it says our reflex should be less than or equal to 95 dBHL. That should be fairly straightforward. Any kind of normal pure tone thresholds, we typically expect reflex thresholds to not exceed 95 dBHL. So in this table and in the other tables that are going to follow throughout these slides, anything that says less than or equal to 95 dBHL essentially means reflex at normal intensity levels. So right ipsi is a normal reflex. But if you look to the right of that, for our left ipsi, our right contra, and our left contra, those are all absent. So why are those absent? Well, let's take a look here. Let's go ahead and look at, we have a 45 dB conductive loss in the left ear. Again, the left middle ear is our problem. That means any reflex where the left ear is the probe ear is going to be absent, which means left ipsi, right? Because left is both stimulus and left is probe. And then right contra, because left is probe. Those are both going to be absent. So that leaves us, the only one left to answer is going to be the left contra. Probe is in the right ear, unimpaired, and the stimulus is in the left ear. So why in the world is that absent? You know, you have the hearing loss in the left ear, so you might say, shouldn't that be elevated as opposed to absent? Maybe just really high as opposed to absent? Well, then you have to remember that we have limits to our instrumentation. The limits of our instrumentation is going to be about 115 dBHL. So we take 115 minus 45, that gives us 70. Is it possible that a reflex could have been there? Yeah. Is it likely? No, probably not. So, you know, although we could have changed that from absent to, you know, present, in most cases it probably would be absent. A good rule of thumb would be when you have air-bone gaps in the stimulus ear greater than 30 dB, you're probably going to have an absent reflex. But so hopefully that explains why we have an absent reflex there. Let's move on to number two. Okay, now we've got just bilateral cochlear hearing loss, so very, very common. It's slightly asymmetrical. We've got a 60 dB loss in the right ear, 40 dB loss in the left ear, and I've got my little band symbols over the cochlea to indicate that that's where our pathology is at. So let's go ahead and look at right ipsi. Why is that less than or equal to 110? Well, that's fairly straightforward. If we look at a threshold of 60 dBHL, and if we grab our table, I'll see if I can find my table here. There's my table. If we look at 60 dBHL and scroll down 1000 hertz, 100 dB, 110 dB or less would be expected. So 110 dB or less for right ipsi. Hopefully that's fairly clear. Left ear, it's the same thing. Anything at 40 dB is pretty much normal as far as our expectations for what their reflex threshold would be. So less than or equal to 95. And then why do we have 110 here? It's because, well, the stimulus ear is the right ear. And the same thing, so that should be elevated the same exact way right ipsi would be. And over here on the other side, why is that in the normal range? Well, the stimulus ear is only 40 dB for the threshold. We know 40 dB produces normal reflexes, and so that's why we have less than or equal to 95. Let's move on to example 3. Okay. So here, this is a tricky one, okay? So this is one of the harder ones. So for the right ear, no, we don't have a spot for external ear on here. That's why I've kind of just moved my band symbol over adjacent to that right middle ear to pretend it's my right external ear. So if we've got impacted cerumen in that ear with a 15 dB air-bone gap, so let's see what we've got going on here. Right ipsi is absent, and why is that might be the question. Well, the key thing here is the impacted cerumen. Remember, if we have impacted cerumen, this is also the case we probably have a flat tympanogram, meaning we can't even see changes in admittance when we change ear canal pressure at all. We're definitely not going to see changes in admittance with the reflex when the impacted cerumen in the probe ear. So right away you can say right ipsi is gone, and also any reflex where the right ear is the probe ear, which is the left contra over here. Those are both absent. So then what about this other one, the seventh nerve palsy? How does that have an impact here? Well, the seventh nerve palsy, because this is distal to the stapedial branch, that means it's below the stapedial branch, which means that yes, there is a seventh facial nerve problem, but it's in an area that is completely not affecting the acoustic reflex pathway at all. That's why I don't have it on the screen at all. Now, if it's proximal or above the stapedial branch, then it has an impact. This is distal, it's below, so we can pretend that left ear distal palsy is completely irrelevant to us, so we don't even have to worry about it. It's more or less a normal ear from our perspective. So let's go and figure out how we got left ipsi and right contra the way we did. Well, if we look at the left ear here, I don't have a pathology mark anywhere on the left ear. That's because, again, we're going to treat it like a normal ear. That seventh nerve palsy is below the level of the stapedial branch. And let me show you what I mean by that. Okay, there we go. Let me see if I can get rid of, there we go, my bar. Oh, got to bring it back. Hold on, got to bring it back. There we go. All right, so here is this is, believe it or not, this is one of the more simplified images I could find of the stapedial, the facial nerve. So with the facial nerve, all I want you to focus on here is this little branch. This is where the stapedius, facial nerve branch goes to the stapedius here. So because the pathology is distal, that means it occurs in some area below here. It could be in this portion here. It could be a little bit lower, right around the stylomastoid foramen area. It could be below here. It doesn't matter to us because it has no impact on our reflexes. Now, if it was proximal and it was having an impact up here on the, I guess, right in this area here, then it would have an impact on our measurements. It doesn't because its pathology is this area or below. So let's keep moving forward. All right, so left ipsi, we have reflexes that are less than or equal to 95 dBHL because the left ear is more or less normal for the ipsilateral pathway. And then what about the right contra here? We have stimulus in the right ear and we have the probe in the left ear. Well, now this comes back to the thing where we have the 15 dB air-bone gap. Yes, we have cerumen there, but that's not the more relevant part here is the 15 dB air-bone gap. So all that's going to happen here is our acoustic reflex thresholds are just elevated by about 15 dB. So if we imagine what is our upper limit there, maybe around 110, 95 plus 15, about 110 or so-ish. I know they say 110 to 115. Let's not nitpick on it. But that just means because we have the conductive loss in the stimulus ear, the right ear, it's just going to elevate things for our right contra where our probe is in the left ear. Number 4. Okay, so now we're moving on to the 70 dB cochlear loss in the right ear and normal function in the left ear. So let's start with the right ear. Well, with the 70 dB loss, it's basically our table. Let me pull up our table here again for us. 70 dB loss at 1000 hertz. It tells us our threshold should be 115 or less, but for some bizarre reason, the authors are saying 110 or less. I'm going to say 115 or less. That seems to make more sense to me. Again, we're talking about a 5 dB difference. Let's not split hairs here. All right. So basically, the threshold in the right ear should just be consistent with the hearing loss degree. Let's look at left ipsi. Left ipsi should be normal, as it shows here, less than or equal to 95. Again, over here, left ear, normal hearing and function. We're good there. What about right contra? Stimulus in the right ear here and probe in the left ear. Well, we've got that hearing loss in the right ear. We've got the reflex in the left ear. It goes back to the same thing. The stimulus ear has a threshold of 70 dBHL. That means that it should be less than or equal to like 110 or 115. And then when the stimulus ear is our left ear, which is our totally good ear, we're measuring the reflex in the right ear. It should be normal. Why is it normal? The fact that we have a pathology in the right cochlea is irrelevant because it's not part of the left contra reflex pathway. With the left contra reflex pathway, we go from middle ear here on the left to the left inner ear to the left cochlear nucleus, left superior olivary complex. We crossed over from the left cochlear nucleus to the right superior olivary complex. Then down to the seventh nerve on the right side, the right middle ear. You can see that right cochlea plays no role whatsoever in the left contra pathway. Okay, so now let's move on to number 5. So here we've got eighth nerve tumor with severe sensorineural loss in the right ear and seventh nerve tumor proximal to the stapedial muscle in the left ear. Let's start with the right ipsi. Right ipsi, we can see our pathology in the right side is our eighth nerve. It's absent. If we've got an eighth nerve tumor, then it doesn't matter. Anything involving that right eighth nerve is going to be gone. So right ipsi is gone. You know what else is gone? The right contra over here, because it involves that right eighth nerve. So get rid of it. It's absent. Let's look at left ipsi. Why is left ipsi gone? Well, left ipsi is gone because we've got a problem with the the facial nerve over here. So we've got left ipsi pathway, which usually goes left middle ear, left inner ear, left cochlear nucleus, left SOC, left facial nerve, back to left middle ear, but the left facial nerve is the problem, so nothing is going to work there. So that's going to be absent as well. And then we've got our left contra pathway. Okay, if we follow this middle ear left cochlea, left cochlear nucleus, crossing over right SOC, right seventh nerve, right middle ear. Did you notice as we went in that pathway, there was nothing impaired at all? We didn't cross any of our band symbols, meaning we had a totally normal left contra pathway. This person has crappy luck to have a eighth nerve tumor on the right side and a seventh nerve tumor on the left side, but they do still have a left contra reflex. All right, let's move on. Now we've got a 35 dB cochlear loss in the right ear, and they've got a middle ear problem in the left ear. It's just a TM perforation. So let's start with right ipsi. Right ipsi, we have a normal reflex. Why do we have normal reflex? We go from middle ear to cochlear nucleus, SOC, back to facial nerve on the right, back to middle ear. Why is it normal even though I've got the band symbol over the cochlea? It's because that threshold is only 35 dB. It's still going to be normal when we look at our table. It's going to be less than or equal to 95 dBHL. What about our left ipsi reflex? Well, the issue here is it's that probe effect. We've got a conductive problem in that left ear. So that means that any kind of reflex we try to measure in that left ear is going to be absent. So left ipsi for sure, that's absent. Also right contra, because the probe is in the left ear, that's going to be absent too. So what goes on with our left contra here? We've got stimulus on the left side, and it goes through the middle ear, through the cochlea, through the cochlear nucleus, SOC, and then we're measuring it, I'm sorry, not SOC, I keep doing that. Sorry, let me start over again with our left contra. It goes through our left middle ear, left cochlea, left cochlear nucleus, and then we go over to right SOC, right facial nerve, right middle ear. So the question is, why do we have a normal reflex for left contra, even though we've got the band symbol over our left middle ear? And that's because even though we have a perf, we have normal hearing in the left ear. Well, how does that happen? Well, an example would be if it's a teeny tiny perforation. It doesn't have to be big, Probably a good example where it's an intentional perforation might be something like a PE tube. But you could also have a spontaneous perforation that just happens to be very small. And, this could happen. All right, number 7. Last one here. Hopefully this is wrapping it up and good time. Man, this is quick. All right, 35 dB conductive loss in the right ear, 35 dB cochlear loss in the left ear. Let's go through it. So let's start with the right ear. It looks like we've got a conductive loss in the right ear, the right middle ear. So that means anything we measure where the probe is in the right ear is absent. Right ipsy, of course the probe's in the right ear. The stimulus and probe are in the right ear. And what about over here, left contra? Our probe is in the right ear. They're both going to be absent because of that right conductive loss. Let's look at these other guys. Left cochlear loss. Starting over here in the left middle ear, going to the left cochlear nucleus, left SOC, left facial nerve, back to the left middle ear. The reason we have that as totally normal is because the magnitude of the loss for the cochlear loss is only 35 dB. Just as a reminder, we go back to our little table here, 35 dB, 95 or less. 95 or less. So we are good there. That's totally normal. Now, how about that right contra reflex that is absent? Let's take a look at this. So we've got probe in the left ear, probe in the left ear, right? The left ear, the cochlea is a little bit impaired, but the middle ear is good. And then the stimulus is in the right ear. Why is it absent? It's because of the magnitude of the conductive loss. Say we have our max of 115 minus 35. That gives us what, like 80 or so? Yes, it's entirely possible that this right contra reflex might be present in some cases. For whatever reason, in this case, it's absent. It's just because of equipment limits that we've exceeded. So, yeah, that's that. So let me go ahead and wrap that up. I think we're good. So I'm going to just let me know if you have any questions, and hopefully you might have a little bit better understanding of the acoustic reflex pathway and how various pathologies might impact it.